Okay, welcome everybody. I'm so glad you could join us today. This is the Fred Hutch Hutch at Home series. And today we have question and answer around COVID-19 with Dr. Pergam. And he'll also be talking about his personal journey as a scientist and researcher. So we're very excited to have Dr. Pergam with us today, and also glad that you could join us. I'm Jeannie Chowning, and a Senior Director of Science Education and Training at Fred Hutchinson Cancer Research Center. And I'm so glad too that I think we have some participants from other parts of the country joining us today as well. So that's exciting. Dr. Pergam is MD and also has a background in public health. He's Associate Professor of the Vaccine and Infectious Disease Division at Fred Hutch, and also the Clinical Research Division. And his specialty is prevention and treatment of infectious diseases, especially among patients whose immune systems have been compromised. So just a quick reminder before we begin that this is a talk geared towards science teachers and their students. So if you have found us through some other way, you're welcome to be here, but just to remember that we're trying to elevate the voices of the students and teachers, especially when it comes to the questions. Please double check that you're muted, especially if you're connecting via a phone. And feel free to add your questions into the chat as we go along, and then we have some Q&A time built in at the end as well. And I'll put up a link for a feedback form. We'd love to have your feedback about this talk, and I'll also talk about what's coming up next in our series. So without further ado, I'm going to turn it over to Dr. Pergam.
Do you mind letting me share my screen?
Yep, should be good now.
Okay, thank you. So first, as I'm pulling up my screen here, I just want to thank you for inviting me to give this talk. Really excited to be talking to all of you about this. It's certainly something that I'd like to not spend so much time thinking about, but I think it is a really important topic. And I think what's really exciting about COVID-19 is it does show, I think a lot of people don't really understand what public health is. And it's given us sort of the general public a sort of an understanding of what public health is and how important it is to our communities. And also a little bit more about infectious diseases and how infectious diseases work. And so I think it's brought a lot of people interested in talking to us about kind of the work we do. And so one thing I'll encourage anyone who's interested, if you have additional questions, I'll have my email at the end, and you're welcome to reach out to me separately if there's something you'd like to address. And if you do have a question, please leave it, and I'll try to get to them as quickly as possible. If it's related to the slide I'm talking about, I'm happy to take a pause and try to answer it as quickly as possible too. And I want this to be some good feedback. I'll try to get through as much of this quickly and let you guys ask some questions as best I can. So I was asked to sort of talk about sort of who I am and what I do. So I don't want to, I hope this doesn't come across as, let me tell you about myself and how great I am, because that's not anything the case. I thought it'd be important to talk about the journey of how one gets to be in the position I'm in now, and sort of how you sort of develop that pathway over time, because it's not necessarily a straightforward arrow that goes in that direction. So I'm an associate member, as she mentioned, at the Fred Hutch Cancer Research Center in the Vaccine and Infectious Disease Division. And I do ongoing research on the diagnosis, treatment, and prevention of infections in cancer. I'm also the Director of Infection Prevention at the Seattle Cancer Care Alliance, and that's part of the reason I'm so focused on COVID at the moment. I'm also an Associate Professor at University of Washington and Adjunct Professor at the UW School of Public Health in the Department of Epidemiology. Sounds like a large laundry list, but that's sort of what academics is about all these different names and things like that. But I think what it really tells you is I focus on prevention, I focus on vaccines, I focus on public health, and I focus on cancer patients. And so if you remember that, you'll be able to follow me along in this talk, I think. So as I said, how did I get there? I think, again, it's really important to understand that pathway to how you get to your career isn't always super straight. So I think it's important to think about this. I think I thought about this as I was putting these slides together, that in some ways if you look at my past, it makes a lot of sense that I ended up here. And then on the other side, it doesn't make sense at all. So I grew up in Omaha, Nebraska. How did I end up in Seattle? It's by a long string of, jobs and opportunities that came along. But, I think most people think of Omaha as a big cornfield, but it's not. It was a great place to grow up, and I had parents that were really interested in science and interested in sort of promoting kind of what we were interested in learning it. And I had a great opportunity as a student to work with a lot of different people that gave me chances to learn about what a pathway in science might look like. But I think I went to undergraduate at Dartmouth College, and I actually studied studio art. So I think all of you were thinking like, you have to go down this pathway of science, science, science. That actually isn't true. And I actually taught art for a year following graduation. And so I didn't necessarily go quickly into a pathway where I was doing research and, I'd done all these laboratory experiments and, I had multiple publications and all this other stuff. I sort of took my time in getting there, and I actually really sort of embraced my liberal arts education. And I think that was really important. At the same time, I did NIH research funding on fungal infections when I was at Dartmouth. And in medical school, I spent a lot of time on a vaccine campaign in poor communities in the outskirts of Managua, Nicaragua. And then I did residency at University of New Mexico, working with Latino and Native American populations primarily. And then I was an assistant professor there in hospital medicine for about 3 years. And that's really where I loved, and I really learned teaching and how to be a great mentor. And had lots of great mentors during my time there, and it offered an opportunity for me to sort of really love that portion of academics. And then something happened. So it's kind of familiar in a lot of ways, but in some ways I had a pandemic career shift. And what I mean by that is I had a basic situation where I was in the middle of an outbreak that was different. And I have a mosquito here because what I was dealing with was this. So this was West Nile virus. And some of you may be too young to remember this. Some of you do. Some of you may not. But West Nile was a huge issue in the early 2000s, where it was spreading across the United States to the point where people who had come in with fever and headache to the emergency room were assumed to have West Nile virus at that time because of mosquito bites that were happening. Now, one wouldn't imagine that New Mexico was a hotspot for mosquitoes because it's a pretty dry and desert area. But what's interesting is there's areas within New Mexico where they do irrigation farming, where they do flood irrigation farming. So they would flood their fields, particularly for chilies. And there's a lot of water that stagnates where the mosquitoes will breed. And so we found this in certain portions of New Mexico where there were large components of the population that got infected. And some people were quite sick with this illness. ERs had huge numbers of people coming in with mild symptoms and evaluations. So it has a lot of relevance to what we're talking about now. And there was no vaccine. There was no treatment. And so we were just managing symptoms and trying to control them if we could. The rates of complications were much less than COVID, and the transmission was not human to human, but more being outside and related to what we would call a vector-borne disease, or something that was happening through something like a mosquito. So what I learned from that was that I kept seeing patients with prolonged symptoms post-infection that at times, in some situations, were really life-changing for patients. So they had an initial infection, they got very sick, and then they never really recovered. And so I developed a grant with some colleagues. I'd never written a grant before, and I sort of just sat down and said, I want to know more about this because I'm seeing a lot of this. I'd like to get some details. And we organized, that process from really start to finish. I literally spent every weekend free calling patients in the guise of the trial to fill out these pieces of information. And I really learned how to do research, from creating the entire protocol to writing the grant to doing the work to writing it up, from soup to nuts, everything across the spectrum. In addition to that teaching and seeing patients, which I really loved, it really opened my eyes to how enriching that experience could be. And I learned, I'd worked at the NIH, as I'd mentioned, and I worked in a lab where I was doing experiments and using a thing to pipette. And I didn't really love that experience of working in a laboratory, but I found that research always didn't have to be a lab, that I could do research sitting at my computer working on numbers or understanding how to develop an appropriate survey instrument so we could ask people questions like you get occasionally in your emails. And then I came to UW after those 3 years in New Mexico to do infectious disease fellowship and I didn't expect it, but I gravitated towards the cancer population because of the particular interesting infections they got and the really wonderful experiences I had in working with them. And then I eventually took on the role of infection prevention director after some goading for some friends. We really felt like this was a great opportunity for me. And that's one real clear thing for people to remember is listen to your colleagues who sometimes know better what's the right thing for you than you do when you're thinking about this. So I think about what my day is like in questions. So here's some questions that I might get in a day. So can a transplant patient bring their favorite bird into the transplant house? Somebody might show me a rash and say, is this hand, foot, and mouth disease, or is this, or more often, like, what is this rash, and should I be working in clinic? I am often called at the last minute, like I'm leaving for Madagascar, a country off the coast of Africa, and saying, should I be worried about infections and what should I do? And the answer to that is always, you should have contacted me weeks beforehand so we get you the appropriate vaccines and other treatments, but people just forget it until the last minute. And then I'm getting lots of questions now. Where can I get my child tested for COVID-19? Should I get serology testing? People call me to say I'm feeling better. Can I come back to work? And then we often get questions about, can you give a talk on COVID? Can you give a talk on tobacco and mold infections? So lots of different things that come by our desk. And so I think what's really fun about the job that I have is no day is really similar. Every time I think I know what I'm doing, I get a question that sort of is a challenging one. And so that, I think, is part of the joy of the academic experience, is getting involved in things that continually challenge you in a intellectual way that is not similar to any single day. So I like to think about this from the standpoint of somebody who looks at experiential, jobs. I like the fact that every day I'm reading new papers. I am learning from colleagues. I'm watching seminars. And I guess if I had a perfect job, it would be a perpetual student. And in a lot of ways, that's exactly what I do. If you'd asked me in mid-December, did I expect a global pandemic with a coronavirus? I would have said no. I would have said it could come any point in time, but I did not expect it this year. And I've certainly learned more than I ever wanted to about coronavirus 19, or SARS-CoV-2, which is the virus that causes COVID-19, than I ever expected. So I think that's an example of sort of how our lives change on a regular basis. And I think as an academician, that's really joyful. But probably a way to think about this in sort of more clear-cut terms is I wear many costumes and hats. And so I work in infection prevention. I try to prevent people from gathering or acquiring infections while they enter our hospital systems. Sometimes that's called hospital epidemiology. I work on outbreaks and epidemiology itself. So I look at overall trends in infections within cancer patients to determine if there are particular risks within patients. And then I focus on specific outbreaks we see and how I can sort of break those outbreaks and to understand why they happened. I look at antibiotic resistance, where the bacteria that we're starting to see and even fungal infections are beginning to develop genes that help them fight against the antibiotics that we use. I spend a lot of time on education and training of people, and I'll talk about that in a minute. And then I actually really focus on communication. So I do a lot of time on social media. I do interviews. I just interviewed with NPR a few minutes ago and wrote a piece for Forbes earlier, where I'm doing this because I really want people to be educated about how to deal with infections and how to approach some of these epidemiologic questions that they may be dealing with on an everyday basis. Like, how can I stay protected from coronavirus as an individual? So these are important things that I think are really critical to being involved in science. So with infection prevention, it's literally trying to stop the daily activities of what happens. And so that's my primary role, is to focus on trying to protect our patient populations. So just some examples of some of the research that I've done is I put together a study to understand why cancer caregivers and families beliefs, what were their beliefs about influenza vaccine, and found that surprisingly, patients, families, and caregivers, they didn't make decisions about getting flu vaccine based on their family member having cancer. And so we learned that we could target that as a potential way to help change their thought process about getting influenza vaccine. We did a modified screening process for tuberculosis, which is an infection that involves the lung, in our people who get bone marrow transplant recipients, our bone marrow transplant recipients. I described an outbreak of a particular rare fungus that was in some of our patients with leukemia, which is a bone marrow cancer. And then I reviewed a large cluster of a waterborne infection called Legionella, which can be acquired both in hospitals and in community water sites. And then finally, I developed guidelines for giving measles vaccines to people who otherwise have weakened immune systems to do that safely, because it's a live virus vaccine. So just some examples of what I might do in my daily activity. So I kind of have the opportunity to do a lot of different things at once, which I think is really exciting. But I think the theme that I like to remind people is that prevention is really better than cure, because cure means you've developed the disease. And if you can prevent the disease in the first place, you don't have to spend your time on cure. And so I really focus on trying to prevent things from happening in the first place so that we don't have to deal with the consequences of trying to treat patients. And then I spend a lot of time in teaching and mentoring. I like to have a really diverse group of students that I work with. It is fantastic, the ideas that they bring to the table, the brilliant, sort of directions they take my research, and also seeing them be successful is probably better than anything that I do myself. The accolades that they get are something that I think really brings me satisfaction in my job. And so it's not just about doing the work and seeing patients and loving that experience. It's not just about, getting national recognition or writing a paper that I feel great about. It's really about seeing the next generation of scientists be brought through the system and seeing how they're going to change the field when I'm no longer in charge of anything. So I encourage all of you to reach out and find people who want to do this kind of work, because this is really our mission in academics. It's not just about us, it's about the future of people getting into science. And we want not only smart people, but we want a really diverse workforce that's going to represent the entire United States. And I really encourage all of you to reach out to people at the Fred Hutch, email us, ask us questions, because opportunities always exist. And if you don't try, you won't know what's available. All right, so let's get into novel coronavirus. And I'm going to begin by showing you a few slides that I showed at the beginning of sort of mid-January. So I think January 21st, to be sure. So this was actually the image that I showed as a starting picture of what was initially described. People were initially calling this Wuhan pneumonia or Wuhan coronavirus, but really the novel coronavirus that is appropriately named now. We don't like to name these after particular cities because they do end up having long-term effects on those particular locations. So coronavirus is named as such because it's a virus, and this is what's called an electron micrograph. It's a very, very close image that's done with special techniques. And what you can see are these little spikes on the edges of that round sort of central virus. And those are the corona, or the crown around that virus. And so that's why they're called coronaviruses. As interest, those spikes on the surface are actually one of the particular focuses of a lot of the vaccine research, to get antibodies against those particular spikes, which may help prevent infection. So basics is they're a single-stranded envelope RNA virus. And what I mean by enveloped is they have sort of a fatty layer around the outside. And that's important because when viruses have that fatty layer, what we call lipids, or sort of fatty material, it's actually they pop off through your cell, and they take some of your cell wall with them to help protect themselves. And in doing so, when it's an enveloped viruses tend to last for shorter periods of time on surfaces, because that envelope will easily dry out and then the virus can't spread. So some of these can last for short periods of time on surfaces, but not for extended periods, for weeks on end, like some other viruses can. So they're they're part of a subfamily of coronavirinae, and then we find them in multiple hosts. So as many of you know, and you've heard in the news, that coronaviruses are often found in bats. And so bats are a common place where we see coronaviruses, but there are many other coronavirus species that exist in other populations. And there are already known 4 to 5 strains of coronavirus that are commonly seen in humans every year that develop minor upper respiratory symptoms. And they've probably been with us for long periods of time. The difference is that this is a novel or new virus where the immune system isn't ready for this particular infection and can lead to more complicated issues. And what we worry about in patients like this is that they can get transmission through respiratory droplets. That whole 6 feet is organized around how far those droplets travel when you cough or you're speaking or singing or doing other things like that. And that would be something where it could hit one of your mucous membranes around your mouth or your nose, your eyes, and then lead to infection. And after infection happens, it spreads throughout the body and can lead to an inappropriate inflammatory response. So I think if you think about it, it's almost like some people have an allergy and they take a particular medication, it makes their throat swell up, it makes them swell. The idea, the inflammation is an excess formulation or an excess component of how the immune system fights against infections. And if it's too robust, it can actually hurt the person who's infected. And so in this particular situation, there are some people that develop these really, really robust immune responses that have negative consequences for the patients. The other thing that coronavirus does is, when you cut yourself, your blood clots, and so you stop bleeding. This virus also seems, because it attacks the walls of your arteries and your veins, can make you clot very easily. And so clotting is a problem where people develop issues with blood clots in areas where they're not supposed to, that can lead to additional complications. So we're learning more about coronavirus. It probably can involve the brain and the heart. It might involve the kidneys. I think as time goes on, we're going to learn what that is. And similar to West Nile virus, we're seeing people with prolonged post-coronavirus symptoms where they have profound fatigue, they might have lung issues or other complications that can develop. So again, coronavirus usually is the common cold, and we have many human strains, but there have been 2 severe coronavirus species that have been transmitted from animals to human, and that's primarily through the meat trade. Or through animal husbandry, or how we have animals that we use within our lifestyles, where we're actually helping to have a population like cows or horses, or in this particular situation, camels. We'll talk about that in a minute. So there was SARS-CoV-1 or SARS-CoV, which was a severe respiratory disease outbreak that happened in 2003, around the same time as West Nile, where there were 8,000 cases that resulted in 774 deaths, and it was reported in 37 countries. It was highly contagious. In fact, large numbers of hospitals developed multiple cases within staff, but actually burned out pretty quickly. And we did not see this continue for long periods of time the way we have with this particular coronavirus. And then there's another one called Middle Eastern Respiratory Virus Syndrome. I think I have a question. Hold on one second. Microphone is rubbing on something. Okay, sorry. I will hold it out in front of me. Thank you. MERS-CoV is a severe respiratory disease that developed in the Middle East, and there was also a large outbreak in Korea. There's about 2,498 cases, resulting in about 800 deaths, so much higher death rates than in SARS-CoV. It's been reported in 27 countries. But interestingly, it's highly contagious, mainly in the hospital setting when patients are very severely ill. They're more apt to spread it to other people. But in households, it's not as contagious when people have mild symptoms. And if you look at where this came from, hold on a second, it came from 2 different places. So SARS, the first SARS, was traced back to bats, which then infected the mask palm civet, which is a small marsupial that was in China. And that was initially found to be associated with the infection. And then in MERS-CoV, which is primarily in the Middle East, it was associated with camels, to the point where somebody demonstrated that if you, they put like vapor rub in a camel's nose, got infected, and went back and showed that that camel had sort of a runny nose similar to any of us would, and was the primary source of that infection to an individual. So camels and camel interactions were the associations how this started. When it spread to Korea, it was person-to-person transmission, but primarily in the Middle East, it's the primary source is from camels. We don't know yet where it comes from in our other populations, and certainly for SARS-CoV, we don't know that yet, or the coronavirus 19. So this novel one, I presented this in early January, where there were early reports in December of this cluster of viral pneumonia in Wuhan, China, which is the 7th most populous city in China. And it was related initially to the seafood market, 24 cases initially, and then as of the 21st of January 2020, there were 218 cases and 4 deaths. It had spread to Beijing, Shanghai, Taiwan, Thailand, Japan, South Korea. There was some question about the Philippines, but didn't know. And there were no known sources to date, but there was increasing evidence that there was actually human-to-human transmission because they'd seen some health worker transmission. And WHO was planning a meeting to discuss this in detail that following Wednesday. And of course, no joke, I was giving this talk to my team and our center about this goal. And somebody texted me literally 2 minutes into my talk that said, "Did you know the first case is in Washington State?" And so everything changed on January 21st. And I say this is a day that remains in infamy because that has led to a major shift in coronavirus and how we've approached it in the United States. Clearly, this was not the only case that entered into the United States, and unlikely to be the cause of all complications, but it was the first awareness that we had it in our midst. And it certainly detected us that Washington was going to be one of the major epicenters initially. And I just want to point out that I, after spending time on social media, knew about this for a long period of time. So I knew about this in the beginning of January and have been following very closely, partially because I'm on Twitter and I use it as a tool to identify early outbreaks. And so I've been following this very closely. And this is Wendy Kwok is a veterinary expert in Hong Kong who I communicated with to find out what was going on, and allowed me an insight to do some preparation for our side in relationship to what we could do to protect our patients. So this is me thinking about how am I going to deal with this as I start to hear about this. This is everyone in their personal protective equipment, face masks and full Tyvek suits, etc. Very scary details and images we're seeing internationally. And I keep thinking of, pandemic. I think I watched, Contagion, the movie again to sort of get myself re-prepared for this. But certainly I had more hair at that time in that image. But I think it was preparation and those nights of thinking and worrying helped me to sort of get ourselves organized for the next steps. So our concerns were that cancer patients are often older, and we knew that older populations were at higher risk. Cancer patients often have what we would call comorbidities or other illnesses that are associated with their underlying disease. And many cancer patients are immune suppressed, which means their immune system is weakened by either their cancer or by the treatment they receive. And we knew from outcomes from other respiratory viruses like influenza and respiratory syncytial virus or RSV, which causes croup in kids, that they were more likely to develop lower tract disease like pneumonia or lung involvement and to death in cancer patients. And despite major efforts to prevent transmission of these other respiratory viruses within our cancer community, we knew that we'd still have patients that would develop this. So unfortunately, unlike many things, cancer treatment can't be delayed. So we couldn't put these off, and we needed to move forward, but we needed to do that safely with patients. So unfortunately, with advanced age, weakened immunity, and comorbid conditions, these other complicated health problems that really put these patients at high risk for major complications. So the other problem is we have lots of interactions. So these are some images of interactions between patients. In the green and the red are 2 individual patients and the number of staff that they interacted with. So frequent outpatient visits, blood draws, radiologic imaging procedures, inpatient-outpatient combinations. They travel similar pathways. They often live off-site in similar quarters in some locations on campus. And so this is an issue about all of the different interactions. And the other direction is also true. So this is an interaction with a front desk staff member and all of the different locations where a staff member who might have an infection might interact with other people. There's frequent outpatient visits, elevators, coffee stations, on bus and transport, lots of ways that people can transmit to each other. So we needed to really focus on how we could stop these transmission events from happening. So we had a lot of decisions. We had to focus on the hospital, we had to focus on our outpatient clinic center, and then interactions between patients and clinical staff, and we had to focus on our laboratory efforts to make sure we could diagnose and identify these patients. So one thing we did is we set up universal symptom screening and testing on arrival. So anyone who presented to the center were screened for symptoms of COVID-19, and then if they had symptoms, they were tested on site. Employees were screened on clinic entry, and again, if symptomatic patients could be deferred, we tried to do that, but if they needed to be seen, we did that carefully with appropriate personal protective equipment. We built testing capacity. So we had on-site testing for symptomatic patients. We developed drive-through stations in our clinical areas for patients and staff. There's been increased local capacity within the state of Washington. As many of you know, there's lots of different sites within the community. And we've been working on home test kits that we could send to patients where they could get tested and send it back in so they don't even have to come into the clinical space. And then we've worked really hard to test all symptomatic employees or anyone who's been exposed during work that might be at risk for developing complications. And this top picture is one of my research team members who actually helped develop some of the testing capacity. And then if we look at our trends in testing, you can see that it just increased over time, the number of patients who got tested. So we ended up doing pre-visit symptom screening and testing of patients. We did pre-surgery or pre-procedure testing. We did it before they got admitted to the hospital. We did surveillance testing for transplant or high-risk patients. And I think one thing that's coming up now is we're doing so much testing that our patients are getting tired of being tested. And so we've been switching our methods for how we test, but it's almost the opposite problem where people are having too many tests that are cancer patients, and we need to figure out ways that we can maybe test them a little bit less. But there continue to be challenges. There are issues with supply chain, and what I mean by that is, imagine that every day you need to get supplies to manage your daily activities. When you go to school, you need to have your right pen and your paper, etc. But if every day you have to look and say, do I have enough paper to do my work every day? That got to be challenging for a time period where we weren't sure we had enough masks, we weren't sure we had enough hand gel. We needed to have enough supplies to be able to take care of patients. And that was very stressful in the beginning because sometimes we had 4 days of supplies instead of needed 3 months in advance. And that's gotten a lot better, but that was really hard to manage. We're changing guidelines. So throughout the process, there were new data that were emerging all the time, and we had to rethink how we were going to approach that. So initially, we decided masking wasn't going to be something we were going to be doing for everyone. And we shifted our thinking on that based on data as it came out and really shifted towards everyone masking in the clinic. So now everyone who enters the clinical space, whether they're the patient, a caregiver, a loved one, or a staff member, is masked. Caregivers and family continue to be challenging because how we test them, how we address them, is still an issue that can be quite complex in healthcare systems. And then I've spent a lot of time on social media and print media fighting against, I think, false information and information that's out there that can be dangerous. So people saying masks can cause people to pass out, or you can't breathe, well wearing a mask. You'll lose your oxygen. It can be dangerous for you. These are not real, but we need to spend time pushing against those narratives because otherwise people will hear the wrong messages. So as much as we're able to, we're trying to get out in front of these messages and really encourage people to do the right thing. So we've developed what we call an infection prevention bundle. So we do hand hygiene, making sure that people are washing their hands really well. We do increased cleaning in the clinic. We have everybody wear masks. We do symptom screening. We focus on physical distancing, where we've gone into the clinic and tried to spread things out as possible. We focus on testing. And then we do a lot of staff education and communication for patients. We've also added into that what we call telehealth, where I would do a physical exam, not a physical exam, but I would interview you over the computer and talk to you one-on-one about your condition and prescribe medications from a distance. And that allows us to still take care of people, but not actually to be in the same room and put people at risk. So I really think infection prevention and the work that we do is about preventing these infections from happening. So we developed a testing infrastructure. We've organized tracing, where once someone's positive, we see who potentially around them could have been infected. We do screening, we do universal masking. We have organized systems to keep sick patients and staff at home. Again, telework, and then remote work for other employees who don't need to be on campus. So all of the guidelines we create, we also share. So we help provide guidelines nationally, but we also make all the work we do. We made those readily available to other cancer centers around the country so they could use them, modify them, and improve them. Because that's really what we should be doing in a pandemic. It should be sharing best practices so that we can all improve. And I think we really saw that with our colleagues around the country, and many of them fed information back to us, which was critical in prevention. So where are we now in King County? Well, obviously we went up in March and we've come back down. We had this low period in March, and then we started to see an uptick. And I think we're starting to see that as the economy and as we've gone into phase 2, according to the governor, where we're opening things again, we're starting to see more exposures. And what we hope is that we can modify this again and continue to shift that down. But I think there's a lot of concern from many of us that there's still a lot of work to be done on this. And I think we don't want to get to the levels of where we were, where the hospitals were really at risk for having too many patients. So I think we're all watching this very closely. There's no perfect solution to do this, but it may mean we need to clamp down on some of the activities that people are doing. And we're hoping that universal masking in Seattle and the surrounding areas in King County will really be helpful in modifying risk. So again, we're going to be focusing on prevention, hand hygiene, masks, physical distancing, our sick policies. We're going to be working towards vaccinations when they're available, caregivers and family. We're working on studies in other forms of prevention. We're doing patient staff education. We're focusing on technology a little bit, where we're doing self-screening. We're working on a contact tracing app that uses Bluetooth on your phone that would allow you to figure out who you've been in close contact with. And we're really trying to provide transparent data so everyone can see what we're dealing with. We're supporting telehealth, and then we're really collaborating, again, with our colleagues all over the country. So one thing that we've developed is some infographics. As an example, this is one where we say practice the 6 C's. Avoid crowds, close contacts, and close spaces, which basically we stole from Japan. They've used this, and it's been a really good mantra. We added in clean your hands, cover up with a mask, and care for yourself. Eat well, exercise, sleep, which are really critical to maintaining important health activities. So these are things that we can make available for patients that they can see and then change practices within their lifestyle. And then, of course, we want to focus on vaccinations. That's coming soon, we hope. I think the science around vaccines is fascinating and interesting. And I think anyone who's interested in this space should be following along with what the Fred Hutch is doing, as we're going to be one of the major sites that's developing these vaccine protocols. I think it's going to be one of the true scientific marvels is to think that we can get a vaccine up and running and as quickly moving forward as we can. Very exciting to see where that's going to go and how this would be beneficial. We hope within months we'll have a vaccine, but I think we need to be patient. And the reason we need to be patient is we don't want to do this too quickly, because those who fight against vaccines and who don't believe in vaccines can really push a narrative that these are dangerous. And we want the majority of the American public to accept this so that we can have protection within our community, so that we can begin to open up more and have the benefits of what, kind of our normal lives were like, where we can travel again, we can go see our friends, and know that we're protected in many of these situations. So last is I want to just mention the social media ID and research. And so one of the reasons I talk about this is I sort of think social media and how Twitter works is almost like a viral infection. Things spread and ideas spread very quickly. I really want to focus on spreading the right type of ideas, science-based information, and really best practices. And so I think it's important that people that work in public health need to focus on this too. And so it's been a real effort on mine to spend time in this space, communicating with experts, commenting on what I think is important, and giving people opportunities to engage in this space. So it's a great place to learn more. but I would tell you social media can also have lots of information which is not helpful. What can be really good is following people that you know are scientists and seeing what they're talking about and who they're talking to and learning about that. It's a great way to sort of get some introductions into early science and understanding the way that scientists think. It can be really interesting and can lead you to some really opportunities for potentially even research and learning a little bit about what kind of research is out there. So my parting comment is this. You can sing this to the Queen song, but I'm not going to do it because my voice is not great. But it said, "No mask on your face, you're a big disgrace, spreading your germs all over the place." And make sure that you don't do that. This is from a colleague in New York City. I think it's important that we all do our part in protecting against COVID. And that means all of you to be talking to your friends and family about why this is so important, to remain socially distant or physical distant from others, to wear your masks in public spaces, and to continue to, if you have symptoms, stay out of the public and get tested. So the last bit is just a reminder that this is a state mandate. It's Mascot Washington, and I want everybody to be thinking about this when they go out into public spaces. It becomes something where when you're in your car, you feel strange without your seatbelt. I hope it's similar, that when you walk outside, you start feeling strange without your mask while we're dealing with COVID. So I think that's my last slide. I'm going to leave this up, so if people have questions, they can directly email me, or I'm happy to take any questions at this point.
Thank you so much. Could you just briefly talk about some of the things that Fred Hutch researchers are doing in terms of vaccine approaches and
Sure.
antibody approaches and things like that?
Yeah, it's a great question. There is the HIV Vaccine Trials Network, which is a big network that's focusing on developing an HIV vaccine. It shifted their focus in the COVID experience to looking at COVID vaccines. So they're helping to develop and design how these trials are put together, who gets the vaccine, how you analyze people, looking at how we look at immune responses to the vaccine, really clearly in large populations throughout the world, but primarily in the United States. And that's being run by Dr. Larry Corey, who is an expert in viruses who's done this kind of work for years. He and Julie McElroth are two people that have really led that direction. There is probably about 6 or 7 labs that are looking at serology, or your ability of your immune response to produce what are called antibodies. It's part of the memory cells, or your immune system's memory of prior infections. It can be really important in controlling viral infections in particular. And so there's a lot of groups that are looking at responses. And then additionally, people like Josh Schiffer, who's a colleague in my division, is really interested in looking at different and novel treatments for coronaviruses. So the drug remdesivir, which is a new antiviral agent that's being used, they're looking at giving it to people at a different time point, not waiting till they're really sick, but maybe at an earlier time point to see if they can prevent people from developing major complications. So lots of research going on from the laboratory and basic bench where people are sitting in rooms and pipetting, to people looking at large groups of patients and who might be potentially exposed. So lots of different things going on at one time.
So there's a couple questions. The first one, once there's an official vaccine, once a vaccine is developed, would it be a good idea to send people back to school, or should we wait until a majority of our school population is vaccinated? And also, wouldn't there be potential problems from developing a vaccine faster when a lot of vaccines take years to develop?
Let me target the second portion of that question first, which is it bad to sort of move this forward too fast? I certainly advocate that we want to do this in the right way. And I think that's really how everyone is focusing on this. They want to develop a vaccine and assure that it's both effective and safe. I think that is the charge that everybody's been given, to make sure that we do this in the right way. So I don't think people have to worry about that aspect. I think the scientists in charge of this have that as their primary goal. I think the difference is there's been a lot of money put into this. There's a lot of research. There's a lot of people working on this. And so we've been able to move something where prior vaccines, it was a smaller group working on this. It took more time. This is something where multiple labs around the country are all focused on this. There is new companies that are developing vaccines. There are international collaborators that are providing data and science rapidly, and that has moved the field faster so that we have these vaccines at a farther way in the field. And interestingly enough, there was a lot of research dollars that went into preparing some of the early data around this that had already been started for other infections that they could then change that technology to focus on coronavirus. So you remember Zika virus a few years ago, there was some of the techniques they learned for early Zika virus vaccines they were working on that they could use for this particular focus. So I think it's not necessarily that people are moving too fast, just the technology is better, and there's a lot of people working on it. So it makes it a process that we think we can get there sooner. The second question about opening schools is a really tough one. I'm not an expert in opening schools, but I think we want to do opening schools safely. I think there's no question everyone around the country is focused on this as a major issue. It has a large effect on who can work. It has a large effect on the economy, but we want to make sure that students and teachers both are cared for safely. And how that's going to be done is difficult. I think some places that have low rates of coronavirus may focus on masking all the people who come to the schools and trying to prevent transmission through that mechanism. Other places may decide to go completely online because of concerns for transmission. So I'd love to see a national policy that were more focused, that everyone could agree upon, including experts in this space. But so far that hasn't really materialized. So I think right now it's a bunch of different places thinking about different things. And I think the vaccines are not going to be ready for early school season, which for many places is starting in August and some places in in September. It's going to be hard to wait for a vaccine if they're planning on opening school. So it's going to be a matter of doing methods to prevent transmission with masking and social distancing, et cetera, in these schools versus doing it all online. And it may be a hybrid of both, where sometimes you're on campus and sometimes you're doing it virtually. So it just depends. Lots of tough questions around that space, but I wish I had better answers. I don't.
Yeah, it's on the mind of a lot of people,
yes,
probably in the audience.
I'm sure many of you are like, am I going to be going back to school?
Teachers or students,
Yeah.
So another question, who do you follow on Twitter that you think would be good for us to follow? Because you mentioned the importance of following scientists who are doing some of the work.
Yeah, if you'd like, I can send you guys a couple of suggestions, because everybody has a slightly different Twitter handle. I really like, I of course follow the CDC at cdc.gov, or to CDC.gov, which is really helpful. They have a lot of information. I follow the Fred Hutch because there's lots of really interesting details from that. I like right now UW Virology, which is at UW Virology, has a lot of information about current numbers that they're detecting in the community. And then there's some really great scientists all over the world that are talking about data. I really like Peter Hotez, and it's Hotez. He is an infectious disease doctor at Texas Children's and is an expert in vaccinations. He's written a couple books about vaccines and is very much in the space. He's actually helped to develop some coronavirus vaccines. You'll often see him on TV talking about vaccines, and he's really a great person to follow. What I do is I sometimes go to people who I see who they're following, and I try to follow others along that way. I also like a couple of women epidemiologists who were real experts around the country. Angela Rasmussen is one who is at Columbia and is also partly here in Seattle, and she has a lot of really good information. She's very strong in her beliefs, and I think it's really helpful. I also follow people that are infection preventionists who are local in different areas where there's outbreaks going on. So a lot of the people I follow also give me information from that perspective. So those are just some quick ones right off the top of my head. But I think there's lots of great voices out there. And I think some really good people that can help you think about how you think about this, how you think about science in a different way. And we don't always agree, which is the great thing about it.
Wonderful. Okay, so let's open it up. Feel free to drop your questions into the chat or unmute yourself.
And don't be afraid, I promise. There's no questions that are really ones you should worry about asking.
I guess I will ask which vaccine candidates you think are most promising. Why?
Sure. I think the one I'm most excited about the candidate vaccine that's coming out of Oxford.
Oxford, yeah.
Yeah, I think it looks really intriguing.
Uh-huh.
I mean, Moderna's interesting, but they've not taken a vaccine from in their pipeline that has gone from vaccine potential to a deliverable vaccine yet.
Yeah.
I think it's exciting, their technology, and interesting that they could get this going so quickly, but I'm very intrigued, and the data looks really interesting from the Oxford vaccine. So
For our audience, could you break down like the main types of vaccines that people are trying?
yeah, so they're really different. It's really complex. Many of them are viral vector vaccines, so they have some virus that they're using as a backbone where you infect someone with a component of the virus, the coronavirus. So it infects you, and then it doesn't lead to an infection per se, but it can expose you to components of the virus, which allow you then to produce an immune response to that portion of the virus. There are others which are called RNA vaccines, which are, again, components of the vaccine, where they use these specifically to encourage the immune system to develop a response. I haven't seen much to date on some vaccines will use a weakened strain of the virus, but of course, I think nobody's really excited about giving vaccines that are related to that are the actual coronavirus yet. We don't feel like that's a safe alternative, but I think there's people working in that space to try to better understand that.
Very good.
Those are
Thank
some
you.
examples. Yeah.
Yeah. And so getting a couple more questions here.
Okay.
Do we expect the virus to mutate like influenza, or will we only need a vaccine once?
Yeah, so that's a great question. Whoever asked that is thinking ahead. I love that that's somebody who has a scientific mind. I'll say that, because that's a great one that we struggle with. We don't know. And I think that's the reality. We don't know if this is going to be like flu, where you need to get vaccinated every year and the virus mutates enough that we need to sort of re-vaccinate. We don't know because we're not sure how this virus is going to look, because we have not seen it before. Interestingly, with other human coronaviruses, after an exposure, you have an immune response that declines at around 6 months, and you can get reinfected even in the same year. What we don't know is how much of that immune response is enough to prevent you from getting severe disease, or if it really can lead to severe disease again. We don't think that's going to be the case. We think it may be that antibody response may last longer. So far, there have been small mutations in the virus, but not enough that we expect it will escape any vaccines that are being developed at the moment. But that's always a concern.
Mm-hmm.
I always think about it in the sense that viruses' whole goal in life is to spread themselves all over the place. They want to replicate as quickly as they can. And so there's millions of copies in some people. So mutations can develop. And if you hit the right mutation, it might escape a vaccine. I don't imagine that's going to happen in a short term, but I think that is something that people are really worried and might change how we approach this. So maybe something that we do need repeat vaccines on. We're not sure yet. But it's a great question, and something that a lot of people are thinking about as we develop these novel vaccines, to be watching very closely for that.
Another question, why did SARS and MERS viruses stop spreading more quickly than COVID-2 has?
Yeah, another really sharp question. I think, basically what's interesting about SARS-CoV-2 is it's not as severe. So there isn't as much death with SARS-CoV-2 as there was with SARS-CoV and MERS-CoV, which had high rates of mortality. But interestingly enough, the population, these viruses are slightly different. So with SARS-CoV, really transmission happened amongst a small group of patients who had really high viral loads and that were often sick. And transmission typically happened after symptoms started. So it's much easier to convince people to stay home when they're sick to prevent transmission. Much of the transmission that happened not in households because it hadn't spread as much, but in particular hospitals. And so you were able to control it much easier. Same thing is sort of true with MERS-CoV, but as I said, it's not as transmissible in households, so community transmission is not as high, and only in really, really sick patients that have massively high virus levels in their nose and secretions, do you see high levels of transmission? And that only really happens particularly in hospitals among really sick patients. So I think for both of them, they tended to sort of be the really sick patients were the ones that transmitted the most. And the mildly sick patients didn't transmit as much. With SARS-CoV-2, there's actually asymptomatic, or what we call pre-symptomatic, people that haven't developed symptoms yet. So you're typically contagious for about 2 days before you develop any active symptoms. So you don't even know you have it, and you could spread it to others. And that at that time frame, you're probably quite contagious with a lot of virus around in your system. And so that is a particular variant of this virus that allows it to spread undetected for long periods of time. In fact, we think coronavirus has been in Washington state since, probably early portions of January. We just didn't know it. And all through February, it was probably transmitting in our communities, and we just didn't recognize it because it was silently doing that. And only when we started seeing really sick patients show up did we really understand that it was in our community. And by some of the work that our molecular people were doing and some of the people doing research in this space, where they were able to identify transmission patterns that we previously hadn't been able to see. So I think that's the unique thing about this virus is for some people, it's mild symptoms that they may think, oh, I just have a headache. It's my usual. I have a little bit of a cough that they might have not done anything about. And that's transmitting to a bunch of people, or they have low-level symptoms and they can transmit that from others.
Great, thank you. If another coronavirus were to jump from bats to humans, would we be better positioned to respond faster in terms of a vaccine? Did SARS or MERS also have blood clotting effects?
Yeah, so in terms of the blood clotting effects, the answer is no. So this is a particular focus of this particular virus. It did not seem to happen as frequently in this population. And so I think it has to do with a better connection of this particular virus to a specific receptor on the arteries and veins. So it's probably a little bit different. And then I think the second, that was one piece of the question. Let me make sure I get the other one. The jumping from bats. So are we better positioned? One would hope that we would be. We had SARS-CoV and we thought we were better prepared, and everybody gets focused on this and we put resources behind it. We invest in public health and everybody thinks about it. And then when nothing happens for 20 years, people start relaxing and they stop worrying about it. And then they, defund things that, they say, oh, we have this in place, but it's not doing anything. We're just wasting our resources there. And so I hope that we've learned from this, that we do invest in public health and that we invest in research in these spaces to have ourselves prepared. It is hard to predict what comes. I mean, I don't envision it will be another coronavirus in the next iteration. It may be other new virus. It could be a new pandemic influenza. So I think for each of these options, we need to have a better public healthcare infrastructure to identify early cases, to ramp up testing very quickly. But I think the one piece that I think we have learned a lot in is developing novel vaccines very quickly. And I think that's an exciting opportunity for us to sort of build on as we move forward.
Thank you so much. If the audience could, you can unmute yourself and clap, or put something into the chat or emojis for our appreciation for your talk today. And
Sure.
Just in the last minute here, I wanted to remind you that on the Science Education Partnership Fred Hutch page, we have a list of upcoming speakers as well as recordings from prior speakers. So this is the place to get all that information. And I want to just tell you very briefly about next week. I hope you'll join us where we have a panel from the Office of Community Outreach and Engagement, specifically the community health educators. And so this is an interesting role for students specifically who are interested in jobs that might have to do with engaging with their communities. And you can see in the bottom right, the giant inflatable colon that they take out to talk about colon cancer. And I think it'll be interesting to enlarge your views of certain types of careers in public health, and look forward to seeing you again next week. And we also have just a reminder, our feedback form, which you can give us some feedback, and I'll put this into the chat. And hope again to see you all next week. And again, thanks so much, Dr. Pergam, for sharing your experiences with us and answering our questions, and appreciate your time today.
Well, and thanks everybody for coming and listening, because even if it had been 2 of you, I would have been excited to do it, but to see so many engaged people, that's great. And I really appreciate you guys listening, and what great questions. It just shows that this is a really engaged group, so it's appreciative. And I can tell there's probably some future scientists listening in, and I hope if anything comes out of this, that you really don't lose that as a future direction. It's a wonderful area to be in, and we need more smart people to be engaged this way.
Yeah, we really appreciate your messages about the importance of diverse scientists and the importance of mentorship. And so thank you for highlighting that.
Yep.
All right, and we'll hope to see you all next week.
Thanks,
all right,
everybody.
Thank you. Bye-bye.
Thank you.